Welcome to AETCM, the emergency medicine channel. Today let us discuss about hemorrhagic strokes and its management in emergency room. We know that emergency medicine deals with various types of stroke. It can be ischemic stroke, inside ischemic stroke, it can be embolic stroke, atheromatous stroke, and we can also get hemorrhagic stroke. Around 15% of the total stroke will be hemorrhagic stroke. 85% of the stroke will be ischemic stroke. So to identify hemorrhagic stroke, it is very difficult in emergency room, but some clinical findings may point towards hemorrhagic stroke. The major difference in treatment between ischemic stroke and hemorrhagic stroke is ischemic stroke, we always try to thrombolize the patient if the patient comes less than 4.5 hours, that is the golden hours. Whereas in hemorrhagic stroke, if the patient is having a bleed and raised intracranial tension, that is a major concern there. So control the intracranial pressure, that is very, very important. But afterwards, once the patient is stabilized, then we have to search for what is the cause, whether it's a hypertensive bleed or aneurysmal bleed, whatever it is, then we have to correct that also. If it is an aneurysm, then coiling, all these procedures are required afterwards. So in hemorrhagic stroke itself, there are different types of hemorrhages. It can be intracerebral hemorrhage with or without intraventricular extension and subarachnoid hemorrhage. These are the two important types of bleeds. One is intracerebral hemorrhage without extension to ventricle or with extension to ventricle, then subarachnoid hemorrhage. ICH's intracerebral hemorrhage, the major cause for this is hypertension. That occurs due to the rupture of small perforating arteries in the brain, AV malformation, bleeding disorders, or patient is taking any drugs which can produce bleed like warfarin, dabigatran, like that, pixibans, drugs like that. Platelet disorders like thrombocytopenia, ITP, or dengue, leptospirosis, malaria, all these things can also produce bleed. Autoimmune diseases, again SLE, conditions which can produce bleeding disorders also can produce bleed into the brain. Subarachnoid hemorrhage, the most common cause is aneurysm. Aneurysm can bleed. Aneurysm for many years that they may not be having any clinical finding. Suddenly patient will present to ER with acute loss of consciousness, severe headache, seizures, like that. So aneurysm are one of the most important cause for subarachnoid hemorrhage. Again, AV malformation, bleeding disorders, trauma, whatever is given for ICH is applicable for this also. So patients can come with intracerebral bleed there. Now we can see the sites of ICH and SH. Common sites of ICH is the most common site for intracerebral bleed is putamen. Putamen is in the basal ganglia. Other structures in the basal ganglia also can be involved there. Again, lobar bleed can be there, thalamus bleed can be there, caudate nucleus bleed can be there, pontine bleed can be there. But if you see the bleeds in the anterior circulation and posterior circulation, the major difference in anterior circulation is or anterior brain parts are in a larger cavity, larger skull cavity. So even if there is a bleed, brain will adjust. It may not produce much clinical finding, but whereas posterior circulation strokes like thalamic bleed or pontine bleed will become deteriorate very fast because it's a small compact compartment. Any bleed into that compartment can produce pressure effect there and patient can deteriorate very fast. So that is important between anterior bleed and posterior circulation bleed. Now common sites for aneurysms are anterior circulation, anterior communicating artery at the bifurcation of MCA from ICA, origin of PCA from ICA, posterior circulation at the apex of basilar artery at the origin of pica and superior cerebellar arteries and basilar arteries. So these are the common sites of bleeding. But what we have to remember is there is a difference between anterior circulation bleed and posterior circulation bleed. Anterior circulation bleed, if it is a large bleed, it can have pressure effects. But in posterior circulation bleed, even if it is a small bleed, it can produce pressure effects. So in a patient who is having posterior circulation stroke, how much ever small it is, patient should go to ICU. That is very, very important. Any patient who is having posterior circulation bleed, he has to be taken care properly. Other patient also we have to take care properly, but here patient can deteriorate very fast, so he require intensive monitoring. Whereas a anterior circulation stroke, since larger space is there, a small bleed may not produce any pressure effect on the brain, but a larger bleed can produce pressure effects. That patient also should be treated in ICU. Now these are the types of bleed you are going to get in the brains. There is subarachnoid hemorrhage, lobar ICH, intraventricular extension of bleed, subdural hematoma, extradural hematoma, intracerebral hemorrhage. So these are the common types of bleeding. Other than that, pontine hemorrhage is there. Other areas also can be involved in bleeding. Now, saccular aneurysm, that is one of the important type of aneurysms we are going to see in clinical practice. Saccular aneurysm is the most common type of aneurysm and account for 80 to 90% of all intracranial aneurysms and are the most common cause for non-traumatic subarachnoid hemorrhage. So this is also called as berry aneurysm because of the shape of the aneurysm. They mostly see in the bifurcation of the arteries. You can see the aneurysm here. Now these are the common sites for aneurysm, like anterior communicating artery around 49%, posterior communicating artery 20%, and you can bury aneurysm in the MCA is 34%, posterior cerebral artery and that bifurcation of basilar artery 4%. Like that, internal carotid artery, some aneurysms can be there, but you can see anterior communicating artery has got maximum number of anterior communicating artery, and MCA has got maximum incidence of aneurysms. Now we will see what are the clinical features of any bleed into the brain. You know that blood is a irritating substance inside the brain. It can produce a lot of irritation. It can produce edema surrounding that. It can produce pressure effect only because of the bleed, and surrounding edema also can produce pressure effect. Patient can have raised ICP features like vomiting, headache, all these things, and other features of stroke also can be seen. And we can see the common findings like severe headache, that is called as thunderclap headache, vomiting, seizures, papilledema, loss of consciousness. Almost all features are due to raised ICP. You can see raised ICP produces headache, vomiting, bradycardia, hypertension. Neck stiffness is seen in subarachnoid hemorrhage. So neck stiffness is a classical feature of meningitis, that is an irritation to the meninges. Here also we get irritation to the meningitis by blood, that's why it produces neck stiffness. So other than meningitis, the classical condition which produces neck stiffness is subarachnoid hemorrhage. And if you are doing a CSF, you can see the blood in CSF also, but routinely we don't do CSF study in subarachnoid hemorrhage or any stroke. Second, third, fourth, fifth cranial nerve involvement are very common if there is a compression of these cranial nerve by aneurysms, and before rupture itself, some of the patients can have these findings. Now, if we see the prognosis of the patients, in general, supratentorial hematoma, that means anterior circulation, mostly they are anterior circulation, they have a good prognosis. If less than 30 ml have very good prognosis, 30 to 60 ml have intermediate prognosis, and more than 60 has got very poor prognosis. But whereas infratentorial hematomas, even if it is a small hematoma, it has got a bad prognosis. So we have to be very careful in that type of bleed. We have to monitor intensively for this patient. Extension to intraventricular system and the bleed for the posterior fossa Low GCS, initial presentation with seizures or altered behavior, all got very bad prognosis. In that, seizures are got very bad prognosis because seizures, mostly seizures are produced by the bleed itself, but seizures can increase the metabolic need of the patient, and again this seizure itself can produce the ICP. It can deteriorate the patient very fast. So there are some conditions which can deteriorate the patient very fast. One is high degree fever. We have to control the fever whatever is possible, like paracetamol or cooling, external cooling, like that we have to control the fever. Then hyperglycemia or hypoglycemia, both can produce deterioration in patients. Then important thing is seizures. If patient develops seizure, that also deteriorate the patient very fast. Persistent high BP can deteriorate the patient very fast. Even if patient develops hypotension, so hypertension can produce deterioration, but if the patient develops hypotension, that also produces deterioration. That is because of the ischemic penumbra effect that we have discussed in ischemic stroke. You can see here there are different types of bleed. It's first one is a intracerebral bleed. You can see white patches in the CT. CT white patches are always indicates bleed. Second, CT shows interventricular hyperdense shadows, that is blood in the interventricular system. You can see the surrounding edema of edema also that sometimes can put a pressure on the brain parenchyma. Sometimes mediastinal shift can occur. Both these CTs we are not seeing any mediastinal shift. Here you can see subarachnoid hemorrhage in the prepontine and sylvian fissures. Again, subarachnoid hemorrhage, you can see white shadows in the sylvian fissure. There is subarachnoid hemorrhage. Again, subarachnoid hemorrhage, initial phases and late phases, it's very clearly you can see the white shadows in the CT scan. But here there is no midline shift. We have to always look for the midline shift in whatever CT we take. Now, how to manage? So immediately whenever the patient come with acute stroke, in emergency room we always prefer to take CT scan because of few reasons. One is it takes very limited time, maximum 5 to 10 minutes we can get a CT scan. We can rule out a bleed by a CT scan. That is the advantage. We may not be able to pick up the ischemic lesion in a CT scan, but we can rule out the bleed in a CT scan. And we know that 85% of the strokes are due to ischemic strokes, and we can thrombolize. If the patient comes in less than 4.5 hours, we can thrombolize the patient. That is the advantage of CT scan. So in hemorrhagic stroke, CT scan is always better. In acute bleed, CT scan will pick up the blood you have seen the previous CTs. We are not going for MRI. We have to take a CT scan, and we have to diagnose bleed in the intracerebral compartment. Now, once you diagnose there is bleed, we can keep the patient in a neutral position, but head end should be slightly elevated to 30 degrees. If the patient develops a seizure, then we have to keep the patient in a recovery position, that is left lateral position we can keep. Otherwise, normally patient will be lying down on the bed with a 30-degree elevation of the head. And whenever we are treating a patient who is having raised ICP due to any reason, we should not unnecessarily disturb the patient. We should not examine the patient repeatedly. We have to only check the pupil, that is more than enough. Initially, we can have a quick neurological examination, which all areas are involved, we can see, but painful stimulus and other stimuluses should be avoided. Unnecessarily giving pain to the patient can deteriorate. We can see sometimes we will be assessing GCS. In the GCS, one of the major thing is give pain and see the response. Try to avoid this type of examination in a patient who is having bleed. We are not going to give any benefit for the patient even if you understand the GCS in that type of patients. So try to avoid painful stimulus in patients, especially don't try to put tracheal suctioning or Ryle's tube. Once you stabilize the patient, don't do anything. and we have to wait. So keep the patient in 30 degrees, unnecessarily don't give any painful stimulus. Then other measures which can transiently reduce the ICP, you can hyperventilate the patient. But that is only possible if you are ventilating the patient, mechanically ventilating the patient. You can increase the respiratory rate and do hyperventilation, and you can see that patient's PaCO2 can be raised more than 30 to 35 millimeter of mercury. That can be done. It is a short acting measure to reduce the ICP. But you can see that whenever there is a raised ICP, patient will be rapidly breathing. It's a mechanism, body's mechanism to remove carbon dioxide, and that will try to produce vasoconstriction and reduce the cerebral pressure. So it's we have to try that in a mechanical ventilator. That can be tried. Next thing is we can give mannitol. Mannitol can be given in a dose of 0.5 to 1 gram per kg, and whenever we are giving mannitol, we have to make sure that this is given very fast. So if you see the dose here, 1 gram per kg, a 70 kg individual patient may require around 70 grams of mannitol. That comes around 3-4 bottles of mannitol. So you can see many doctors, they give 3 bottles of mannitol, that is 300 ml of mannitol. 300 to 400 ml of mannitol should be given over a period of 1 hour. So continuously giving mannitol as an infusion is not going to help you, because we can see some doctors start 100 ml TID, mannitol infusion is given over 1 hour. That is not correct. Whatever you are giving, you have to give it fast so that the brain edema can come down. If you are giving it as a slow infusion, it will act as only a diuretic. So we have to be very careful. Mannitol should be given at least 300 to 400 ml, 20%, that is 20 gram bottle should be given over 1 hour. So 300 ml in 1 hour will be a very good treatment option, and if possible try to maintain the osmolality 300 to 310 milliosmol per kg. So that has to be tried. So if you give more doses, sometimes a patient can have renal failure, and again renal failure patients, it will be difficult to give mannitol because it can sometimes aggravate the problem. So we have to be very careful, and remember these mannitol and all are short acting benefit, and if you are taking the patient for surgery, it should be given only once or twice. Now again, another drug which can reduce the ICP is hypertonic saline or 3% saline. 3% saline also can shift the fluid from the CNS cells to intravascular compartment. So that can be tried. You can give 300 ml of 3% saline in 1 hour. Again, you can remember whatever we are given, 300 ml of mannitol plus 300 ml of saline in 1 hour. Only problem with 300 ml of 3% saline is already patient will have high BP. We have to be very careful. In hypertensive patient, 3% saline can refractorily increase the BP for a prolonged period. So we have to be very careful. If not required, we should not give this type of treatment in hypertensive bleed. Whatever drug you are giving, that all depends on the clinical scenario. If the patient is not having high BP, patient is having intracerebral bleed, there is raised ICP, you need some time for the procedure for the neurosurgeon, then you can try 3% saline. If the patient's BP is very, very high, and if they have a salt responsive hypertension, when we give 3% saline, BP definitely is going to increase. Then if all these drugs are not possible, and if you want to paralyze the patient and completely sedate the patient, propofol will be a very good choice in this type of conditions. That can be started, and we can even try for mechanical ventilation. Propofol should be started if all these drugs are not able to give, or you need immediate sedation for the patient, because any stimulus in that patient is going to increase the ICP, and patient can deteriorate very fast. And low GCS, we have to go for mechanical ventilation. Remember, normally GCS less than 8, we usually intubate the patient, but here even if the patient is having slightly higher GCS like 9 or 10, and if the patient is taken for a neurosurgical procedure, as soon as possible we diagnose raised ICP, better to put the patient on mechanical ventilation so that we can avoid further noxious stimulus, and it sometimes it can produce more damage to the patient. So better to ventilate the patient as soon as possible. Now, once you diagnose raised ICP due to intracerebral bleed, is always involve the neurosurgeon into the system, and they routinely take the patient for procedures like external ventricular drainage and evacuation of hematoma or ventricular shunting. So all these things are specialized procedures, can be done by a neurosurgeon. So in conditions like raised ICP due to a extensive bleed, we have to request neurosurgeon to intervene, and we have to save the patient's life. Now, one of the important factors other than the bleed as such, the treatment of bleed as such, that is hypertension management. Many patients who have intracerebral bleed, they come with intracerebral hemorrhage. Intracerebral bleed come with high BP. So we know that when BP is slightly higher, if you reduce the BP, sometimes the ischemic penumbra, that is that's the area surrounding the core stroke area, that is whether it is a bleed or ischemic area, that is core area, surrounding area may be supplied by the collaterals. If systemic BP is maintained, that collateral circulation will be maintained. If you reduce the BP, sometimes the collateral circulation can reduce the circulation, and ischemic penumbra also may die. That's why we don't reduce the BP drastically any type of stroke. But here, if we think that patient's bleed is due to high BP, and patients who is having systolic BP 150 to 200, acute lowering of systolic BP to 140 millimeter of mercury is recommended. That is very, very important, and we can even target a mean arterial pressure less than 130. So patients with acute bleed with systolic BP more than 220, aggressive reduction of BP with a continuous intravenous infusion of antihypertensive, and systolic BP should be reduced to 140 to 160. For the patients with mean arterial pressure more than 150, also consider to reduce the BP, and consider to reduce less than 130. Mean arterial pressure should be less than 130, and systolic BP should be reduced less than 140. So that should be the idea of a reduction in the BP. We can use drugs like nicardipine, labetalol, esmolol. These are the three important drugs, but at present we have labetalol in most of the ERs. Labetalol dose is 5 to 20 mg every 15 minutes, then infusion 2 mg per minute, maximum 300 mg per day. One important thing we have to remember, we have other beta blockers also other than labetalol. We have metoprolol, we have other types of injection beta blockers. But only thing we have to remember that there are some conditions like pheochromocytoma, cocaine poisoning, where all if we give only beta blocker, unopposed alpha adrenergic action can come into picture, and sometimes BP can increase. So in that type of conditions, these drugs are actually contraindicated. But unfortunately, when the patient comes to emergency room, we will not be thinking all these things. When the BP is high, we always give beta blocker. Sometimes patient can deteriorate if the patient is on cocaine abuse or patient is having pheochromocytoma, BP can increase. But if you give labetalol, that has got an advantage. It's both alpha and beta activity, but it's a predominantly beta blocker. So alpha blocker, ideally in a patient who is having pheochromocytoma, you have to give alpha blocker, control the alpha activity, then beta blocker. But in a patient who is having stroke like this, we will not get time for that. So this drug has got both beta blocking activity and some alpha blocking activity. And if we are not able to use this type of drugs, you can go for NTG. That's a very good drug. NTG can produce vasodilatation. Other drugs what is mentioned in the previous slides are not available at present in India. Nicardipine IV is not available, so we cannot use all these things. Another important drug, that is nimodipine, 60 mg 4th hourly, can be given to reduce the vasospasm. So vasospasm is a very important factor for causing death in subarachnoid hemorrhages. So we have to give nimodipine 60 mg 4th hourly in patients who is having subarachnoid hemorrhage. So labetalol can be used to reduce the BP. In almost all conditions we can use labetalol. There is no contraindication for labetalol, only you have to take an ECG and rule out heart blocks. Otherwise labetalol is a very good drug. Even cardiac failure also we have to avoid beta blockers. Severe cardiac failure we have to avoid beta blockers. So otherwise labetalol has got no major contraindication. So we can give almost all types of hypertensive emergencies. Labetalol can be used. Now, there are some special situations like patients can have bleed because of the drugs what they are taking, like warfarin, dabigatran, or drugs like rivaroxaban, AETCM. These are drugs are used actually in conditions like atrial fibrillation or conditions like SLE, other types of cardiac problem, metallic valve replacement, antiphospholipid antibody syndrome. All these conditions we use these type of drugs to prevent blood clots. So if the patient is on dabigatran and if he develops bleed, we have to give Aneurysm. So that drug can be given in 5 gram. 2 separate vials are available. You can give 2.5 milligram. 2 ampules can be given for a bleed. Other drugs like rivaroxaban, AETCM, we have no other option, no other antidote. We can give FFP and vitamin K are not, we can give FFP, but vitamin K is not effective for rivaroxaban and AETCM. Activated charcoal can be tried. No specific antidotes are available for rivaroxaban and AETCM induced bleed. Warfarin is a well-known drug. It's a vitamin K antagonist, so we can give FFP and vitamin K. Prothrombin complex concentrate that can be tried in drug toxicity like rivaroxaban, AETCM. 30 international units per kg can be tried. Warfarin routinely respond to FFP and vitamin K, so that is the advantage of warfarin. But other drugs like dabigatran, rivaroxaban, AETCM, they are safe, very safe drugs in terms of bleeding. But once the bleeding occurs, they are very difficult to treat, very costly to treat. So warfarin is one drug which is very easy to treat because it responds to vitamin K and FFP. But the drug has got lot of complications, lot of interactions. That's why nowadays we use dabigatran, rivaroxaban and AETCM. So we have discussed about one important condition, that is intracerebral bleed. We have to target 2 important things. We have to control the BP, we have to control the raised ICP. To control the BP, labetalol is most important drug that can be tried in almost all types of bleed. We have to target a mean arterial pressure less than 130. Whereas controlling the raised ICP, surgical procedures are always better. Other treatment, medical treatment, all will only bridge the time. So you can try raised head end by 30 degrees, avoid any painful stimulus, then 3% saline around 300 ml in 1 hour, mannitol 300 ml in 1 hour, and hyperventilation with the help of mechanical ventilation, propofol to sedate the patient completely. These are the options available, but surgical intervention is the best option if the patient is deteriorating. We should not waste our time doing all these things, all the medical treatment, because medical treatments all are temporary and we will not be able to make sure that these drugs are working in the patient or not. That's why surgical treatment, if it is available, that is the best treatment for raised ICP. A neurosurgeon intervention is always required there. Thank you.